Welcome everyone to the final session of our SAMHSA COE webinar series this year. So glad to have everyone in the Zoom room, as it were. I know I like to start all of our events with a question. And so I was thinking today, since it's very hot where I am in Washington, DC, I'm curious what people's favorite frozen dessert treat might be. You of course don't have to share, but I was recently having a conversation with someone about the fact that I love vanilla ice cream and also those like coconut popsicles. I just thought it might be a refreshing way to start the conversation today. So while we give it another minute or two for more folks to join in the room, okay, I want to see sort of what everyone treats themselves with when it's too hot out. Ooh, lemon Italian ice. Oh yes, absolutely gelato. Little Debbie strawberry. I like the specificity. It's the Little Debbie brand. Bluebell, the best. Oh no, I started, there's gonna be Alden's, there's gonna be Bluebell, there's gonna be Eddie. Okay, mocha ice cream sandwiches, great. Another Bluebell. Okay, DQ or Oreo. I mean, fantastic. Ooh, a caramel banana popsicle. See, I didn't think now I'm gonna want one of these after the webinar, and I'm not, my work day is still going on. Tillamook ice cream, nice cream. Frozen boba. Okay, yes, I do like the boba, the bubble tea, shaved ice, water ice. Yeah, I really didn't think through the consequences of now I want some, like now I'm gonna be hungry through this, this event. Dairy, okay, milkshake and malt from the middle of nowhere dairy at. Yes, absolutely. Those can be the very best. So as folks continue, and please, engage with each other about these frozen treats, I'm gonna go ahead and get started here. So welcome to the art and science of integrated care partnerships. Next slide, please. So I'll be your facilitator for today. I'm Kristen Potterbush, Senior Program Manager with Primary Development Corporation. Next slide. So a little bit about PCDC. We're a national nonprofit. We've been doing this work in the space of integrated care and advancing health equity for a little over 30 years now. And we really believe in walking the walk and talking the talk around making it possible for individuals like yourselves and organizations across the country to have what they need to provide the top tier of care for the individuals that they serve and also for their staff. And so we have a variety of different ways that we can support organizations with advancing the best practice of their organizations, from technical assistance, events like this, and all the way over to capital investment. Next slide, please. So this is funded by the Substance Abuse and Mental Health Services Administration, and the views and opinions and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of CMHS, of SAMHSA, or of the U.S. Department of Health and Human Services. Next slide. So this year we worked hard to hit on all of these topics. And if you weren't with us for the journey, at the end of this presentation today, we'll have some links so that you can catch up on what happened on our previous 3 webinars or even dabble in our previous 2 years. But we've really been focusing in on what are the critical concepts that you might need to advance integrated care within your setting. Next slide. So speaking of your setting, speaking of you, we would love to learn a little bit more about where you're at. And every time we put this up, it does not capture the multifacetedness of this incredible audience. So when we inevitably do not have you on the bubble list, tell us in the chat who you are. I want to make sure that we recognize everyone who's here at the proverbial Zoom room table, because we get so many folks who do incredible work that allows us to advance as a field, and we just don't have enough options. So if you see yourself, press the bubble. But if you don't see yourself, tell us who you are. Tell us what you do. Excellent. Student, yes, clinical pharmacist. So key to making integrated health work. Administration, thank you. Wonderful. Department of Services, adult program specialist. Thank you for coming today. Behavioral health technical assistance specialist, CCBHCs. Yes. Oh, hello, Patty. Thanks for joining. Executive leadership. Thank you, Tammy. Population health pharmacist. Ooh, wonderful. Technical assistance of eval, nonprofit adolescent mental health consulting. That is important work. Thank you. Project director for mobile healthcare. Yes, mobile clinics, mobile healthcare. Bringing it to people where they're at. State Department HIV prevention, thank you so much, and keep them coming in. We want to recognize that what makes integrated health possible is everyone who's on the call today, everyone who is part of the multifaceted services that the individuals that we serve benefit from. And it's not just about, cut and dry behavioral health and primary care. It takes everyone coming together to collaborate. So keep telling us about yourselves. Next slide. So for those of you who attended our previous webinar, just want to let you know that the tip sheet for it is done. Chaim's going to put a link in the chat, and this has some of our top best of hits, if you will, from the prior webinar. So if you didn't attend, or if you did attend and you need a reminder, or it just would be handy to have on your desk or on your desktop, just go to this link and give it a download. We hope that you find it helpful for yourself or your colleagues. Next slide. So on today's webinar, we're actually going to be doing this panel style. And so what we are hoping to hit on are sort of around these three key areas. Thank you for joining us from the Puerto Rico Department of Health, Jacqueline. So we're hoping to identify ways to leverage data and QI practices when engaging and strengthening your new and your current partnerships. We're hoping to talk a little bit about sort of how you can understand the unique needs of supporting and maintaining partnerships that are part of integrated care models and settings. And then we're gonna talk through some of the opportunities for creating those partnerships and the critical components that go into maintaining them, because that can sometimes be a little bit different place to place, even if you don't have sort of that integrated care model. So next slide, please. I want to make sure to introduce our esteemed panelists who will be talking through sort of those key focus areas today. So first up, we have Pamela Mattel, who is the CEO of Coordinated Behavioral Care. She's a highly qualified executive. She has over 38 years of nonprofit experience and 15 years of experience in executive specific positions, where she's been advancing high quality whole healthcare integration and innovation within the behavioral health care, primary health care, and housing spaces. Her leadership and management has consistently resulted in multiplying the reach, delivering on promise of quality integrated care, increasing revenue, and participating in numerous city, state, and national forums. She continues to reimagine healthcare and social services by convening diverse groups of stakeholders, actively supporting collaboration, incorporating design approaches, measuring results. And she's consistently secured innovative models and programs for complex organizations like CCBHCs within care transitions, technology-enabled care, and opioid collective impact responses. So we're really grateful to have her on the call today. Thank you so much for joining us, Pamela. Next up, we have Julie Schilz. She is the Senior Director of Integrated Care here at PCDC. She actually joined in 2022, and we're really grateful to have her on board. And she supports a lot of the portfolio and leads the portfolio around our primary care integration work. But prior to joining us at PCD, she's held several executive leadership roles with community provider and payer organizations, developing and implementing strategy focused on value, delivery system reform, and primary care transformation. And she's really dedicated her career to working within innovative solutions in healthcare and communities that are person and family centered with a focus on equity. She's led multiple national and regional and local improvement initiatives, concentrating on innovative interventions for care delivery in the context of community primary care and public health. And last but never least, we have Isaac Kastenbaum, who is our Vice President here of the Clinical and Quality Partners Division. Isaac is a a member of the senior executive team here at PCDC as well. And he joined the team to deepen expertise of the nonprofit in primary care transformation and value-based payment, and to expand the breadth of partners, stakeholders, and communities where PCDC can have an impact. And prior to PCDC, he served in a variety of roles at New York Presbyterian Hospital as the Director of Population Health, Partners in Health as the Director of Business Development, and Brigham and Women's Hospital Quality Improvement Manager. So we're really grateful to have this sort of breadth of expertise today as part of our panel, because we can really capture sort of some of the different components of the partnership conversations that we really need to be having as we continue to grow as an integrated care space. So next slide, please. That's my cue. So that's I think we're ready to go full screen then with all of our faces and videos here, and kick us off with our first question. So I'm curious, and maybe Isaac, I'll put this one to you first to kick us off. You know, the webinar's title concept is it's an art and a science of partnerships. And so to kick us off, you know, where is the art and where is the science, and how would you recommend that each of these components should be or could be supported and engaged with?
Thanks, Kristen. Hello, everyone. So it's a great question. Where's the art and where's the science? I think particularly in the space of integrated care, I mean, there's been so many studies, so much evidence generated. There's so many sort of best practices that exist. There is endless regulatory structure and payment structure that everyone needs to adhere to. And then there's endless data that are available that could be used, that should be used to drive quality improvement, to confirm sort of appropriate compliance, to monitor and support the workforce and all the work that they're doing. Those are the areas where I see sort of the science. It's the things that have been established, the things in which we have to operate. And then the art, I would just say quickly, it's all about how to get the various actors working together. So organizations are founded with very different cultures, operating under very different regulatory and payment regimes, which shape their day-to-day practices. And people are trained in very different schools and very different perspectives. And I think the art is really sort of the softer stuff of how you get everyone to work together on common patient-centered goals, how you get the team to recognize or multiple organizations to recognize that there's more strength as the collective as opposed to each as an individual. So that's kind of how I see the art versus the science, or the art and the science.
I love that, the more strength as a collective. So Julie, what would you add to sort of this question and what Isaac was speaking to?
Yeah, I agree with everything that Isaac has said. I might add to the art, agreeing with it, that around the relationship piece, and sometimes when we're looking at integration, we don't think about the staff that are participating in these integrated relationships from the different disciplines, and we bring the two disciplines together, but we don't think about how they need to work together sometimes, and don't create the relationships between the different staff, and don't set maybe even some of the ground rules, because sometimes there's those moments where maybe something isn't going right, and allowing the opportunity to have the workflows of, hey, let's talk about it if it's not going right, and giving that permission when those relationships start to be able to have those conversations. Also, maybe setting some structures that allow for, let's assume good intent, even if things are frustrating and maybe not working out right, so we can have some conversations, because sometimes these partnerships are developed by leadership, and it may feel uncomfortable for staff when the relationships are being developed to have those types of conversations. So it just needs a little bit of permission to be able to get together and pick up the phone and have a conversation to maybe work through some bumps in the road that might be happening. And, you know, as Isaac mentioned, in terms of science, I would agree, the evidence, the data, the QI science, all of those components for me really sort of formulate the science in these relationships.
Thank you for shining a light on that, particularly around sort of the staff conversation, which is all of us, and all of the folks who are on the call today are part of what makes these conversations and partnerships successful long-term, but oftentimes, as you were speaking to, aren't always mentioned or considered as part of making this sustainable. So I'm curious, Pam, you know, what would you want to add sort of as far as this art and science conversation? What do you feel sort of is part of the missing pieces of the puzzle that, you know, makes the painting beautiful, and also, you know, I don't know, maybe it's painting by numbers because it's the art and the science, you know? Oh, Pam, you've been trapped by audio. If you could, no, your audio is currently off. If you could.
You're still on mute, Pam.
Yes.
There you go.
Can you hear me now?
Yes.
Okay. All right. I have multiple microphones, so I apologize. So thank you for putting out the nice metaphor about painting, because as Isaac and Julie were talking, I was thinking about the importance in partnership about telling a really good story, about having a narrative that people can relate to and want to like sort of lean into the collaboration and the partnership. And so important in our country right now with so many different polarizations happening, important for us to remember that sort of this art of partnership is, as Isaac and Julie were saying, the importance of remembering who to invite to the table, how to invite them to the table. There are some lovely books on the art of gathering, and how important it is for us to pay attention to the detail about how we can invite people and make them feel really valued. And I think the other piece that I'll add is the importance of, as we're thinking about partnership, really addressing our issues around equity, access, challenging the voices that haven't been at the table through systems that are racist, et cetera. So we need to really feel comfortable with that and make sure that we're bringing the right people to the table. And right, I mean by becoming a lot more inclusive.
So I think that's a great segue to our next question. And Pam, why don't we start with you, because you're sort of speaking into that anyway. You know, when we're talking about expanding and we're talking about bringing more folks to the table and also having these conversations of whose table is it to begin with, you know, when we're talking about integration within health settings, what do we really mean? And sort of how can these human-centered approaches and responsive systems that I'm hearing you already start to speak to and encourage us to think about enable partnerships, you know, sort of per our topic today?
So I'm going to make an assumption watching the list of participants that everybody in the audience has been really working on integration in a lot of different ways. And that none of us really are newcomers to the topic. So what's helpful for us to think about as we've really been working on integration for a couple of decades now. And one thing I think is to continually taking the challenge to take what we know at micro levels and then purposefully widen the lens for as much inclusiveness as realistic at that moment in time. And what I keep finding is the static definitions and descriptions that we're all putting forth really start to convey an end point. And the wiser we are about integration is to really feel grounded that this is an iterative process and it's based on what we keep learning. So for example, I've changed my language from using the word silos to the continuum of integration. And I found that when I was doing that, when I talked about silos, the people that were in the room got into a frame of reference of the problem. And when I talked about the continuum of integration, people changed their frame to how do we solve for greater intervention? And it just sort of comes back to me about the importance of how we talk with each other and not to go too fast on assuming that we understand our language and how it helps or hinders us. And then the other thing that I'll mention is, it'll be a theme of mine, I think, today, is progress on integration, and when you mention human design, is really about bringing the consumer into the room, and not just to get their feedback or input, but for them to be true advisors and descriptors of the experience as we go through the iterative process and help us make the design rather than just give us the feedback on our ideas.
Thank you so much for sort of speaking around that and calling us in around sort of how we're thinking and the words that we use. And, you know, when we say integration, we are using a word for something that practices might have been in place already. And we need to be absolutely aware of that. Julie, what would you add to this conversation? Because I know that that's something that you sort of really have centered a lot of your career around as far as equity goes. And I know that you are also passionate about sort of integration and the definitions therein. How would you sort of speak to what we mean when we say integration and, you know, the human-centered approaches and responsive systems therein?
And I just want to echo what Pam said of bringing the voice of the customer, the patient, the families, the communities into the process. And, you know, not only do I think those of us working in the space of integration, do we have passion around that, we also have evidence that shows the work is better when we do that. And it is a core attribute of the science of human-centered design when we do that. And when we have that be central to that work. I would, you know, one of the sayings that we have with quality is we say quality is never done. So Pam's use of the word iterative process, you know, that is core to this work as well. You bring your structures in, you start a process, you bring a workflow in, you're working within integrated care partnerships, but you're using the quality improvement structures and the data to see, you know, are you accomplishing what you're hoping to accomplish? And if the data is showing you that that's not happening, then you iterate, you use human-centered design, you use the voice of your patients, your staff, the new evidence that comes in to help you understand if you need to tweak and redesign as you move forward. So I think that is a living process that needs to continue, because the needs of the community, the needs of your patients are always changing when you're doing this work. And sometimes there's a feeling of, you know, potentially a little bit of a feeling of chaos because you never reach that endpoint. But it's also an opportunity to feel that you're always being innovative as well.
Thank you for sort of talking us through your perspective on that. I really value that. And then Isaac, sort of what would you add to this dialogue around what we really mean here and what we're really thinking about?
I think just building off of Pam and Julie's comments about making, I think with integration, you have the risk of just piling on endless healthcare jargon because it's about bringing together people from different disciplines, different organizational settings. So you bring multiple sort of dictionaries to the table, and you sort of get at the risk of getting stuck in that. Pam and Julie both commented on putting the patient or the community at the center of this. I think too often in healthcare, we make the patient or the community work for us. And integration has to be an attempt to flip that situation on its head and make the various services, actors, organizations, frontline staff work for the patient, make it sort of one-stop shopping, to use a cliche. I think there are a few industries where we as consumers or patients as consumers have to do so much navigation on our own. We wouldn't put up with it in other industries, but we do in healthcare. And I think integration has to be an attempt at addressing that sort of not customer first, not community first mentality or service delivery model that we have in a patient-centered, equity first sort of lens or perspective.
I really love that sort of framing of it. And I think that's an interesting sort of counter to our next question, which again, I'm going to pick on you with this, Pam, because, we're talking about sort of this expansiveness and patient-centered and really flipping current models on the head, but let's acknowledge that, developing and maintaining partnerships may not have actually been what each of you set out to do when you first began your careers. You might be inspired by some of what, you were just discussing. It doesn't necessarily center on that development piece. And so I'm wondering, it could be the case for many folks who are in our audience today that, you really didn't set out to develop and maintain partnerships as a key part of your position. So Pam, how do you orient around it? Did you have to shift your lens at all here?
Yeah, thanks for that question. So, my core training is as a social worker and also as a family therapist. So I've been trained to really think in systems, but I have to say that, when my field of vision, when I came to start the work, was really more in contained single systems. And a lot of those systems had more sort of developed partnerships. So over the years, especially in relationship to what we've already started talking about, partnerships have meant looking much more broadly and finding gaps and prioritizing and then investing time to cultivate those partnerships. And sometimes really getting out of my comfort zone to talk with other fields, other people that aren't sort of typically in the circle that I'm used to traveling. And I travel these days a pretty large circle. I shifted from thinking about the system, the single system I was working in, to really make myself think about the purpose of partnership is to improve the community's health. And with that lens, as we have all been saying so far, I had to see partnerships, from the ground up, from the community and the consumer's view. The other thing that really happened for me along the way is to change from a more transactional mindset, even though I'm a systems thinker, from what you can do for me in this partnership to what I can offer you. And I come to almost all of those opportunities with that in mind. What is it that I really can offer you with no expect of return? And I've found that being more generous with ideas, with materials, with connections, signals my more genuine intent and builds trust, which I know is an important component of everything we're talking about. And I will say, you know, there are many colleagues, really trusted colleagues I have that approach this differently and have different ideas about that kind of generosity, noting concerns about competition. And so I think that's also a really important piece for us to talk about.
I appreciate you sort of bringing that up in the spirit of transparency. A lot of us are in the same space. I mean, we got a question already in the chat around, you know, what are the resources and, you know, opportunities as far as grants and philanthropy here. You know, we all want to do this work, but sometimes there's sort of a finite amount of capital that we're all trying to use so that we can advance this and continue to grow and mature as a field. So I really sort of appreciate your framing of that, sort of how we can expand. And, you know, I think that brings us to our next question, which I'm going to throw to Isaac sort of to start with. You know, we are different, you know, in terms of the organizations and providers that are all functioning within integrated care settings, right? And so a lot of organizations, when we're talking about partnerships, are coming into, you know, into the room, into the negotiation with different needs and different visions and different goals. And so I guess sort of have a couple questions here within this, but, you know, first wondering, you know, Isaac, can you speak about some of that interplay of trust for what Pamela just brought up around partnerships and, you know, what some of the concrete best practices are for building trust within and between organizations that may come together, but with such different, again, needs and visions? What's sort of the nitty gritty of making this work?
Yeah, it's a great question. And I think about sort of trust at three different levels. I think there's trust at the patient level, because that's where we're starting this conversation, is just because you're introducing a new service, whether you're operating it yourself within your clinic or you're bringing in a partner to operate something, and you introduce the patient like, hey, do you know we offer primary care now? You still need to convince the patient that integrated care is actually better for them and maybe easier for them, and that you're the site where they should be receiving more holistic or more robust care. And so I think trust has to be established or expanded there. I think at the frontline staff or provider level, so whether it's across organizations or disciplines or departments, staff need to trust each other that each actor will reinforce the other actors' sort of efforts with the patient, that everyone is aware of the services that are available in their mutual departments or mutual organizations, that they'll keep each other up to date about that. And then at the leadership level, it's easy for two organizations to say they're going to work together, but the leaders are really responsible for making sure there's a shared culture of respect and collaboration, making sure that there are systems in effect that reinforce trust and reinforce the sort of good intentions of frontline staff providing care. I think your second part of your question about sort of best practices to do that, none of these things I think are rocket science, but you sort of need to prioritize the time to do it. So having staff shadow, walk in the shoes of staff at the other organizations, tour the other organizations' facilities as if they were the patient, see and experience how the other service or discipline is being delivered, setting up actual regular sort of bi-directional transparent conversations, and at a level higher than case conferences that really talks about the systems issues that Pam described earlier. And then really setting up time again regularly to review successes and challenges, and using the like quality improvement science of root cause analysis to look at like what created success and what created challenges, and making sure you revisit that quite regularly. I think the last thing I would say is you have to be fairly egoless or without ego in the process. Otherwise, it's no different than the service that you're providing today, possibly in a siloed manner. So those are some of the best practices I would highlight.
I I appreciate that. And, you know, I was gonna sort of hang on that sort of being, you know, being curious and egoless within partnerships came up in some of our conversations preparing for this conversation today. And, you know, someone in the chat mentioned something that I think speaks to the fact that we are different when we come into organizations. And, you know, I would say that there absolutely there are isms within our healthcare system. There's sexism and racism, oppression, transphobia, all of these things play out in our individual fields, as well as when we bring other organizations in. And, you know, I think it is important, as the comment was made, to not speak in euphemisms about this. And as you sort of were saying, Isaac, to acknowledge this, and let's be egoless, you know, in terms of also leadership, but also in terms of what we can do to advocate and to be the buddy system for folks when we see that maybe something's going on, maybe someone isn't being heard, someone isn't being listened to, or, you know, someone needs our extra support. And I think, yeah, I think that goes into sort of that piece that you were speaking to, Isaac, around that egolessness and that openness. And it does kind of remind me, Pam, of what you were sort of talking with our first question. So, you know, I'm curious what you would have to add to this particular conversation around, you know, acknowledging the different needs and visions that are part of partnerships within integrated care settings, and how you build trust within partnerships, and, you know, within interdisciplinary individuals who, you know, may not have planned when they were in school to become part of an integrated care setting. You know, I think these are complex parts of when we get it right, it's beautiful and it works well, but there's sometimes a gap between where we start and where we want to be.
So I think you put like 50 questions on the table for me just then. So
just pick one. I'm very good at combining. Yeah, just pick one. Pick your favorite one, Pamela.
And thank you for calling out one of the comments in the chat. It made me also think about being overt and sensitive in partnerships to who has the power in the room, and how we use that power sort of more equitably. So when I walk into a room, I know regardless, I walk in with a title and I walk in with different privileges. And so how do I make sure that that doesn't become a barrier in the room, but it becomes a lever to invite and encourage and support all the voices at the table. So I think that's one piece. And then also about the comment about the power differential is to help those who don't have enough current power in the room by mentoring and supporting and making connections. I think that's an important piece of building partnerships and building trust, is that I'm willing to give to you what I have in the moment, so that we create more equitable conversation. I would offer that, at least just on the partnerships and trust and power.
Thank you. I don't know, Julie, if you want to hop in here at all to add your voice to this.
Yes, and you know, when I started out in nursing 35 years ago, the dynamic between nursing and physicians, there was definitely a power dynamic, and it started to change from a professional standpoint because physicians came to the table, and it was also something from a quality standpoint, because conversations were not happening. So organizations such as the Institute for Healthcare Improvement came to the table and said, this isn't okay because it's impacting patient care. So I would add to the dialogue that organizations and the leadership in organizations are coming to the table. So through my experience of having mentors and having structure and leadership within organizations, it it has helped me bring myself to my professionalism and come to the table and provide that support to those who are early in their careers, and be support for them and create that structure. So it's a bit of a pay it forward type of mentality. So while it, I hope that it's happening in organizations and there's enough transparency and ownership to be able, when because we've all probably in many cases experienced negative dynamics and the power control, that we can step up and acknowledge it when it's happening in a respectful, professional way, and also show leadership from that perspective as well, and call it out and create the structures so that it doesn't continue to happen, and figure out ways to address it and create different cultures in the environments as well. But I appreciate that question because it has existed in healthcare organizations.
Thank you for speaking to and bringing up the fact that, you have lived experience, reconciling all of these pieces, and you might not currently practice in the way, you did as an RN, but you still see that, and you still have opportunities to, intervene and be part of the conversation for moving things forward in a different and better way. So, shifting the conversation just a little bit, and I will add, we're getting some great questions in, and if I'm not able to work them into our set questions, as many of you know, we have our open office hours that goes from 3 to 3:30 for those who are able to stick around. So we're saving your questions if we can't get to them now for that open chat time. But, shifting gears to sort of the QI and data part of this, Isaac, how would you recommend someone or an organization, again, acknowledging what we're already talking about, different needs, different goals, different visions, but how would you recommend someone or that organization, a given organization, could leverage data to start a conversation with an insurance company or another similar stakeholder, folks who, to one of the questions in the chat, might have some resources or other opportunities here to bring to the partnership?
Yeah, I think if you're going to a health plan or you're going to a funder, I mean, you're likely looking for more support or better reimbursement for the good services you're providing today or the services you hope to provide in partnership. The things I would really see as important from a data perspective are like what you're good at. So what are your positive outcomes, using measures that matter to the audience. For the health plan, it might be quality scores, it might be utilization control or reduction, really talking about the geography or what's unique about the community you cover. Health plans have to think about sort of their penetration into certain communities, their coverage of, and I use community sort of as a large umbrella term, both geographic and sort of demographic. It's important to talk about the capacity you may have. So coming to the table and saying that, like, I have a 10-week backlog for appointments, may be a challenge, but talking about how you're hoping to open up capacity through partnership would be valuable. And then I think, being upfront or honest about where there is patient or community need, where there are disparities or difference in care being delivered, or where there are service gaps that can be filled through the partnership or through further integrated care that will move the needle that the health plan or the other funder really cares about. If you can anchor the conversation in those data points, then you almost have sort of a baseline to move from and to come back to a conversation 2-3 months later about how things have improved, how if you get support, their support is helped, and if you didn't get support, how that support, could be more helpful than ever to move things forward.
So Pam, pivoting to you now. So sort of going off of what Isaac was saying, how would you anchor that conversation around leveraging data and sort of those components when you're talking with insurance companies or other stakeholders that might be a little different than organizations that are in the integration space, maybe traditionally have had conversations with around partnership?
Yeah, I think maybe I can take a few of what Isaac offered and sort of weave it into a really recent example. So all of us know that in the news, the issue about children and the mental health crisis is almost a daily article. And then in our larger IPA network, we have been prioritizing the importance of children's services because it's important to the community as well. So what I recently did was we have a quality improvement meeting with one of the local managed care nonprofits, the largest managed care in actually New York State. And so we were talking about children's services, and I came to the table prepared, understanding that it's an important social issue, it's an important medical issue for the plan, and it's a pain point for providers. And so at the table, I said to the managed care plan that CBC has been prioritizing children's services for the multitude of reasons, and that we recently pulled data just to better understand what's happening with our kids. And we discovered a couple of indicators that have been out of our awareness. So it was good information for us. For example, the one we came was one of the gaps in care, which was our children who were on psychoactive psychiatric medications have not been engaging in metabolic screening, which is really a best practice. And that out of 3,000 children, 30% of them had not had any metabolic screening. And so I started that conversation with the managed care plan. They said, oh, that was something they had not been looking at, but that they were also, I knew this, interested in improving care with children. And that opened the door to say, what can we do together to improve this one measure? So my strategy was to anchor this in a public health concern that a lot of people are sensitized to, understanding that the health plan is going to want to improve their scores and reduce cost, and bring something compelling to the table, which is I already pulled the data for us, and that as CBC, I am already going to work on this, but I'd love for us to work together in partnership to see what we could come up with. I didn't ask them for a better rate or anything else, but that is an end goal, that if we can really work together on improving care, then I will have a better value proposition because we both have skin in the game at that point.
I love that, and thank you for providing sort of that case study of sort of how you phrased it and how you approached it, and again, you had that end goal in mind, but you were opening up the conversation, like you said, about a topic that you knew would be sort of shared concern. And Julie, I want to make sure to get your perspective on this, because I know you have a lot of deep expertise around these kinds of conversations from a perspective from coming from a lot of working at these organizations. So how would you recommend an organization come into the conversation to leverage data to start a conversation with an insurance company or a stakeholder around that?
Well, and as you mentioned, Kristen, I worked for a national payer for several years, and couldn't have been set up better by Isaac and Pam, on the conversation. You know, and it's not much different than any conversation with anyone you're trying to have a partnership. Isaac talked about it. Know your audience, know what their needs are, and that for a payer, it really is about the payer in your community or the national payer who you may be wanting to have a conversation, or the Medicaid agency or the Medicaid managed care organization you want to have a conversation with. What are the needs in the community? Is that your patient population that you're working with? Are there gaps that you know of, as Pam indicated? Are you a willing partner to address those gaps? Are you coming in the spirit of looking to be a partner and look towards closing those gaps? What other elements do you know within the community that you can tap into? What are the structures that you have available? Or do you know that the payer has some either data or other programs that you can tap into that they're wanting to be able to provide in the community? So it's really about doing the research, understanding what they may have available that you can tap into. What do you bring to the table? And starting those conversations one step at a time. And even if there's potentially a conversation that doesn't feel like it went as well as you would have hoped, I wouldn't give up. And I think a lot of times as clinical individuals, it's also good to talk to the clinical folks at a payer organization and start with conversations with them, because a lot of times there's some synergies in terms of mission, vision, and value, and ability to have conversations. And many times you may also be part of professional organizations in the communities if your clinical staff within your organization may also know clinical staff within a payer organization as well, and you can kind of tap into those relationships also.
Thank you for speaking to sort of both sides of this. And I like, the comment we just got from Olivia. It takes empathy, boldness, fearlessness with sensitive wisdom. I think that's very well said. And I know we're coming up at 3 o'clock, which is, the end of sort of this hour of more formal conversation. And then we open it up to questions from more folks. But I do know that oftentimes folks have to hop off at 3 o'clock. So just a reminder to those who have to hop off, the recording and the slides as they are, there are actually some resources on the slides from our presenters today. Those will get sent out. The recording will be up in a couple of days. So if you're not able to stay for the full conversation, we invite you to tune back in after the fact or engage with the slides therein. So sort of because we are coming up sort of on the end of our formal hour, I'm going to jump us around a little bit to sort of our last question on the list. And then we can come back to some of the other questions we didn't get to in this last half hour for our more open conversation. So sort of kicking it off with Julie. So how would you say that quality improvement and data can be a part of supporting sustainability from a partnership perspectives? What are your concrete recommendations to ensure that the energy expenditure around those are worth the outcome? Sort of talking about the strategy to invest in those QI and data components and why it's worth it to actually make that investment.
Well, I think I'd go back to kind of starting with a foundation. If you're looking at a partnership related to potentially some type of intervention, thinking about the evidence behind it, And then I think it was Isaac, you may have mentioned something along the lines of measures that matter. And, you know, in order to be tracking that, you know, having the data infrastructure to be following that. And when you're having the partnerships really coming together and aligning on what are those key items that you want to be tracking to know that the partnership is working for both parties. And that sort of gets, that kind of aligns with what you talked about, Kristen, in terms of, you know, is the juice worth the squeeze in terms of the partnership? Is it efficient for both organizations? Are you really accomplishing the goals that you want? Is it achieving the goals for the patients? Sometimes you can think about things that you think will work, but if it doesn't quite have the backing of evidence, if you're not following data or you don't have some common goals that you've really developed with a partner, then you may be spending a lot of time on something that really isn't bringing either organization value. And there's one thing, you know, as if we didn't know in healthcare that there isn't a lot of free time. The last 2 years have definitely shown us that. So it is worth spending some time on both that art of relationship and having the conversation and setting out the structure and the science of knowing the regulations, knowing the data you want to see, creating the workflows and the process, and having the evidence that you know, is backing what you're wanting to create for the community.
Definitely, definitely. Isaac, what would you sort of say to this, you know, around the QI and data being worth the squeeze, or, you know, high cost, low yield, or low cost, high yield, you know, this energy expenditure, the strategy, and, you know, how to support sustainability here?
Yeah, I guess from my perspective, if you don't look at your integration efforts through a quality improvement lens, it will never be like worth the squeeze, or you'll never know it's, you know, sort of worth the squeeze. So, you know, I have been involved in plenty of integration efforts where we build great workflows, great EHR integration, great partnerships, and like 3 patients get served by the program over 9 months. And to me, that is maybe is really valuable to those 3 patients, but it's not necessarily scalable, and clearly doesn't meet a need in the community like we thought it would. So I think it's really important early, like as soon as you start to integrate, whatever that means in your setting, you check in early and often, you know, sometimes at the end of the day, or like a daily huddle, or weekly at least, and you continuously visit or revisit what's happening, because then you can make that decision up front or earlier as to whether the juice is worth the squeeze, whether you need to reposition the partnership, or whether it just wasn't meant to be, or it's not meeting the community or clinical need. I guess I would say, like, it will likely be worth the squeeze if you put in the structures to support it, which is not always easy to do.
So Pamela, what would you sort of say to this? And feel free to use metaphors like, you know, juicers and, you know, blenders. You know, what are our structures here? No, sort of, yeah. How would you set things up to, you know, get that glass of orange juice that you originally intended to get?
So I have found, and I have another example of like a collaboration integration. I have found that when I am engaging in a conversation with an external partner and we're complaining about something together, that there's an opportunity for a problem to be solved. And so I'll give an example. In another organization, one of our services was a detox in a substance use organization. And I was with my colleagues who ran a detox in a hospital. And we were both complaining about the cycling in and out, the recidivism of our patients. And we were really trying to find how to have a better collaboration and partnership, and we just happened to be talking about that. We decided to identify the cohort of patients that were cycling in and out of each other's detox. And we found a cohort of about 40 people that were using our detoxes as a place to live. So they would come to mine for a couple of days, get discharged, go to the other one. And out of that sort of complaint and common pain point, we came up with one much better understanding of who the people were, the patients, what really mattered most to them. I mean, we say that frequently, what matters most, start where the person is. This example really pushed us to get out of our frame of coming up with workflows that would satisfy our organization and really focus on what mattered most for that cohort of people. And we really were very disciplined, and I'm happy to say that because of that real focus on what mattered most to that cohort of patients, that they really made some significant improvement. Of course, I have good data behind me to then bring to another opportunity on integration and reducing recidivism in inpatient settings. So the conversation just really reminded me of that example. And thank you, Glenn, for identifying complaining is the great American pastime, and really how we can flip that around to be solution-oriented opportunities.
I love that. Thank you. So we have a couple questions that we didn't get to, and definitely have a question from the audience. If folks who are still in the Zoom room, roughly it looks like 98 of you might be. If you have specific questions, put them in the chat. We'll try and get to them. And if we don't know, we'll be honest and say we don't know, like I did earlier. I'm not someone who knows a lot about the ICD-10 codes. But one of the questions, I don't know if she's still on, but that was asked earlier was, how do we get each partner to see things from their partner's position or perspective? Sometimes middle leaders create such overwhelming barriers by protecting turf and being invested sort of in status quo that the vision and direction of upper leadership isn't possible to be realized. And, it can be to the disadvantage of the patient at the end of the day. And it's so frustrating, end quote. So I'm wondering, Julie, do you want to sort of kick us off on this one?
Yeah, this is when I usually tap into seek first to understand. I usually find if someone's really holding on to something, they are feeling a lot of control. It's a lot of times there may be fear. They're not feeling a sense of, either a path forward, or they just can't quite feel a path of being able to give up what they're doing and be able to replace. So I usually just ask questions or try and find out more to see if there's a way to be able to get to a different path. So, when I bumped up against that, and I completely appreciated that question. Usually I find that the control is just really, there's just something else underlying. And if you can try and figure out, is there a way you can get to replacing where that person feels much more comfortable with a new path forward? But it's usually a lot of questions and a little bit of trial and error.
Many PDSA cycles.
Yeah.
So Isaac, I saw you sort of, reacting and sort of agreeing with what Julie was saying. So I'm curious to get your thoughts on this. How do we get partners to see things from their other folks' position and perspective, especially within sort of organizational, for lack of a better word, hierarchies?
Yeah, and I think about Glenn's comment about complaining being the great American pastime. Not everyone is comfortable complaining in like a public forum, that you might find some similarities or commonalities between your two units or organizations. I was once involved in an exercise where it was two separate organizations, both led by very protective, sort of turf-driven individuals. And we had a outside mediator come in to do this exercise to try to force complaining, where it was, most people probably say force being vulnerable, but I would argue is sort of force complaining is like, name the top 3 things that you stress about, about your job every day. Name the 3 things that you think matters most to your staff, and name the 3 things that matter most or you hear most critique of from your patients. And everyone drew that up individually, and then it got put up on the whiteboard or on the screen, and it sort of forced that complaining conversation of, oh, we really do have similar issues, or I can help you solve some of those problems because we've solved it over here, or my service will help, fill that gap. And so in a very turf laden situation, that kind of structured conversation really broke down some of the barriers to seeing each other as solutions and as partners in addressing some of your day-to-day challenges. It's a little over-structured than I would normally recommend, but it worked in the most turf-heavy environment that I was in.
What I'm hearing is force senior leadership to complain, and things will maybe you can resolve some of this. But it makes sense as far as sometimes you have to start the conversation somewhere so that folks become more aware of sort of everything that's at play. Pamela, I'm curious also from, your role in your experience in these spaces, what is your perspective on, this middle leaders creating potential barriers and vision and direction of upper leadership not being able to be realized and sort of navigating that? I also saw you really, it seemed like what Julie was sharing was really resonating with you around, listening and seeing and sort of, seeking to understand.
So a few things, and thank you also, Julie, for putting out seek first to understand rather than being understood. I'll throw out there to the audience another lovely book called A More Beautiful Question. There's 2 volumes, and I'm sorry, I forget the author right now. Really helped me understand the many different ways to think about a situation by continuing to find better questions. So I highly recommend the book. And just as an aside, which is sort of related to what we're saying, I've found that when I'm faced with a difficult situation, thank you, Warren Burke. When I found that I'm faced with a difficult situation, I force myself to write questions down, and it's not uncharacteristic that I will write about 100 questions, and about a handful of them are good questions. And so having the patience to really keep at it until you come up with a good question that will make sense to your audience, that will help get to another level, as Julie was saying. The other thing I want to offer to the conversation is recognizing the environment in which we're operating, how so many of our systems have grown up in different, I'm going to say that word, silos, and that not only is our treatment systems and our healthcare system in separate pathways, but so is our financing system. And so everything, and our policies and our practices, So everything that we're doing, and I think you mentioned this a little bit earlier, Julie, is about coming to the table with a learning mindset. And if we can continue to move away from failure ideas more towards inquiry and learning and being intensely curious, because each time we do get a little bit better, I think it helps us move through a lot of the issues that we've been talking about and celebrating the learning as compared to the barrier. So I don't know if I really answered your question, Kristen, but I was sort of off on a tangent thinking about those things.
I think all thoughts are relevant here. I don't think there's not a, I don't have like a teacher's handbook over here. I'm not like checking off if people answer the specific things. No, but I think what you were speaking to is really critical, especially if, you know, I think all of us in this integrated care field have to go in with that learning mindset, because of, as you said, the silos, we're trying to figure out how to navigate things while providing services. It's all sort of happening at the same time, and there's opportunities for improvement and there's opportunities to overcome a lot of barriers. You know, folks seem to be very much resonating with case studies and these concrete examples. So I'm going to pull one of our questions that we didn't quite get to, which was, what have been some of the toughest conversations that you have had with partner organizations, or even in terms of mergers or formal affiliation conversations? And if you could go back in time regarding those tough conversations, what would you have done differently? And bonus point, I said I didn't have a teacher's handbook, and I'm saying bonus points if QI or data could have played a supportive role. And Julie, I'm curious to sort of kick it off with you on this one.
Yeah, it was one of those teachable moments. We were looking to create a primary care organization, looking to create a partnership with a community radiology organization, and we wanted, you know, this is, you'll all be not surprised that it didn't go well. We were looking to ask them to expand their hours, and didn't, I will say it was quite a few years ago, didn't come with any data in the process, and just kind of said, hey, we want you to add some weekend hours. And that did not go over well in the first conversation. And we had a really good relationship with them, and had a nice structure that we put a dent in that relationship, and had enough, you know, enough foresight to go back to the table. We had data that was the reason why we were going to them. We knew that in our patient population, that adding some Saturday hours would be good for our patient population and their needs. Brought that together. It was linking to some quality metrics that we had, and some value-based program models that we had. So packaged that all together with them, and, you know, we were able to go back to them and bring the ask. But what we also added to it was that there were some times that they had added some hours in the week, and we were able to say, going back to those hours and say, you know, we don't need those hours anymore if we can, you know, exchange for these hours on Saturday. And looking at the information, we can shift if that would work for you. And we were able to rebuild the relationship. And for me, you know, professionally, it helped me understand the power of bringing the structures of QI, the structures of data, and really thinking about working in a business relationship and partnership, and how to think about what someone else would need in the relationship to the table to have the relationship work, and how to think about that. So wasn't great at the time, but luckily, helped me in the 20 years since in my career.
Thank you for speaking to that. I think that our conversation is probably something that resonates a lot with the folks who are on the call, a very familiar conversation. Isaac, how about you? What are some of the toughest conversations you might have had with a partner organization, or in terms of mergers or former affiliations, and what you could have done differently in retrospect? Same bonus points apply around QI and data. They could have played a role.
Yeah. So as mentioned in my introduction, I've worked at a lot of large health systems, which there is always a power and a reputation dynamic, to say at the least, in the community at large and in relationship to the community providers. And so one example I think of is at a large health system. We were attempting to integrate a community behavioral health provider who was, probably 100th of the size of the healthcare institution I was working for in terms of staffing and revenue, et cetera. But they really had all of the access to the right behavioral health services that our patients needed on the inpatient side. And we didn't just want your typical transitions of care program or semi-warm handoff. We wanted a real integrated model where their staff were on site at the hospital, we're doing the intake, we're doing the first visit at the hospital, and then we're working with the patient to get them back to the outpatient setting in the community. When that relationship started, many of my peers on the hospital side, we sort of thought oh, we know the patients that are best for this program, we'll find them, we'll send them to you, we know exactly what you need, we've got it. And after probably 4 or 5 weeks, there were 2 referrals. Of those, one was accepted, and that individual stayed in the program for 3 days. And so it was a real, sort of comment on, not bringing ego to the table of the hospital, thinking that we had all the great ideas of what would work. And from that moment, we kind of flipped it on its head based on the data we were reviewing, to let the community agency drive, what patients were best suited to participate in interdisciplinary rounds, to help say oh, that one's a good, that patient's a good fit, that patient's a good fit, that patient's not going to be a good fit for our services. And yeah, just to let the community partner drive, and to present them as having equal authority, or position them as having equal authority to the hospital providers and clinicians. That was supposed to be sort of our hallmark project, to show that the hospital was learning to work with the community. I think we had lots of bumps and bruises, but it did end up working after 3 to 5 months of very tough conversations, mostly around clinician ego, about who was best positioned to choose the patients who would benefit from the integrated services. So yeah, that's the example I would give of give yourself time to review the data of what's actually happening on a day-to-day basis. And to Pam's earlier comment, make sure you're giving equal space to people at the table, or equal time to people at the table to contribute their, real and different expertise. That was key for this thing to ultimately shake out to be a success.
Definitely, I like to call back to that egolessness, but it's hard when you're bringing 2 organizations who feel that they know their own populations, to say, hey, we know what people need, and sort of then having to backtrack and unpack and say, wait a second, maybe people know what people need. Maybe the community-based organization is better suited here. How do we backtrack? Pam, I'm curious, what example you might be thinking of as we're talking through these around, some of those tough conversations, and, if you had a time machine, what could have been done differently, especially, if QI or data could have played a supportive role.
As Isaac was sharing his story, I have so many similar stories, and I think it is sort of connected to the thread that we've been talking about this afternoon, about making sure that what matters most to the audience is what drives the conversation. But the example I have is, and it's sort of based on the ego, this agency that I worked for, that we had a real compelling mission, really community-based, much loved in the Puerto Rican community. And we were acquiring a smaller organization. And so the tough conversation was, I sort of walked in with, the position, you'll sort of be lucky to be a part of something bigger in the community. And what I learned really quickly was our compelling mission was not sufficient for this organization. What was really important was their roots in the community, their community-facing relationships, and how that needed to be honored before I did anything else. The tough conversation was for me to be quiet and listen, not for me to say anything, and really understand the value of, and this sort of, I guess, where I grew up a lot in my thinking, the value of really listening to everyone at the table. And it's not based on position or role. It's really based on what's being said and how you want to listen to it. So if I went back in time, I would have gone to that table saying, there's a tapestry here. We have a big opportunity to build this out. What can you teach us about how to bring care together for the community? And it would have been with a lot more hubris. So I appreciate that they were very good teachers back then.
So I like where that puts us in terms of a tapestry, because one of the things we started with today was around a painting and sort of painting by numbers, that it sort of takes all of us and our time machines of experience, history being the best predictor of future behavior, history just informing us of how we can do it differently this next time around. So I think with that, I'm curious, Chaim, can you go to the next slide? We do have a sort of our standard post questions for folks that we'd love to have individuals who are still on the call today fill out. And then to Cynthia's question, we actually do have some resources that our presenters sent to us that are up. I don't know, Chaim, can you, if you could go to those while folks fill these out. So I know that we sort of put these on, and there was also other questions that came up in the chat around resources as well. But these are sort of some of the creme de la creme, if you will, of what our panelists today felt could be supportive for folks to engage with around furthering knowledge, or maybe just reading to have and then reflect on with the folks that you're with at your organizations. But I know some of what I'm really taking away from this conversation is there's a lot of different right ways to move some of these conversations forward. And there are key components, though, that oftentimes do contribute to the success of this art and science. And it's listening, and it's seeking to understand. And it's taking and measuring sort of everything hand in hand. And it's acknowledging that we have our issues in the health system, we have our isms. It's acknowledging that, there are structures and juicers that we can put into place if we're squeezing oranges. And that there's just a lot that we still have to learn, but I think one of the things I appreciate about having the three of you on is to really clearly hear the wisdom that you have gleaned from as you continue to work and have your private time machines. And I feel like that represents where we're at in terms of this webinar series and really the integration field. I think a lot of us are in that learner's mindset. And because of that, because of all of you who are on the call today, you are advancing the field. And so I know I just want to say thank you for those of you who've been with us for the whole journey this year, and those of you who joined today, from sharing your favorite desserts to downloading the tip sheets, and then when you log off of these webinars and you do the incredible work that you do, caring about this beautiful tapestry that we're all weaving together to make sure that this field moves forward in a truly responsive way. So yes, the importance of language and compassion, absolutely. So yes, just want to thank everyone who's been with us, and stay tuned. We'll be doing another series next year. So hope folks are able to join us then. There's a couple upcoming events at the SAMHSA Center of Excellence. I don't know if any of our panelists have any sort of final words here in our last 3 minutes. Pam, you want to take us out? Any final words of wisdom?
Oh, wow, that was like a lot of pressure, Kristen.
Well, your mic wasn't muted, so I was like, excellent.
Yeah, actually, I want to thank, of course, all of us on the panel for sparking ideas, and mostly to thank the participants for the vibrant chat. A lot of really terrific ideas, things that I'm walking away with as well. So I do appreciate the participation. And I guess the last thing that I will say on this is just to just remind us all that this is a really important journey, and every day when we make a little bit of progress, it really means a lot. Actually, it reminds me of the biologist in South America that told us that when a butterfly flaps his wings, it causes changes throughout the world. And so if we can just hold on to each time that we do something, we are making an improvement in our system for the good of our community.
I love that. We can be the butterflies of integrated care, flapping our wings, to take it to what Julie, flapping our wings for each other, for those of us who work, those of us who are our colleagues, and flapping our wings for our clients, so that, we can be that change. Well, thank you again, everyone who's on the call. I hope you all have some delicious frozen desserts today. Perfect. Thank you, everyone. Take care.
Bye.
Bye.